Okay, so we're live. A warm welcome to everybody joining us here for the final session of day 2 of our 9th annual D3 Drug Discovery, Development and Diagnostics. Today, as you know, is the Diagnostics Day. We've had some superb sessions from the beginning of the day to now, where we've looked really at the challenges, the headwinds in terms of future of disease elimination, looking at that from, let's say, a policy, funding, access, all of those different perspectives, local context, all of that. We've looked at some very interesting, cutting edge, kind of novel point of care diagnostic solutions for schisto, for dengue, for mutations, the G6PD mutation in malaria, and also some of the roads, the pathways in developing barriers when you come to developing an RTT, in that particular case for schisto, but kind of generally as well. We moved from there to molecular-based approaches, so we've had a look at leprosy, tinea, solium, schistohepatobium, and the kind of wider lab-on-chip diagnostic system. So we're there. Some of the issues that cropped up were really kind of central around capacity and capacity building. It's very interesting because this is one of the reasons we wanted to have this particular session, to kind of really get into a local feel, what's actually possible when capacity is used, not just built. So the recognition of what's happening on the ground and bringing that in somewhat. And so it's our great honor that we're joined by two real thought leaders in this particular, and actually doing this, on a massive level. We have Dr. James Mulry from Merck Global Health Institute, the head of the diagnostics program there at the Merck Global Health Institute. We're looking at malaria microscopy, the education program and capacity building program that he has rolled out under the umbrella of Merck. So hi there, Jim, to you. Great to see you. Thanks for joining us. And then we'll follow that with Dr. Morgane Gourlaouen. We've had Morgane speak previously in ISNTD Connect sessions. She's very kindly come on board to speak in terms of the Food and Agricultural Organization, the FAO of the United Nations. And she's going to be speaking really in terms of strengthening veterinary diagnostic capacities. It's kind of an untapped area, really, when you think about it. And the previous speakers, Hendrik Swadowski from Berlin, had mentioned One Health as a global health agenda through which we can float NTDs and kind of develop a stronger case, because all this is about case building and at some level or another to policymakers to drive things forward, whether it's uptake, whether it's deployment, whether it's financing, all of it. So this capacity building could be a kind of way of getting to those people. And so I think that's enough from me. What I would say to the audience, thank you very, very much for joining us. And I would ask you if you could, I realize it's in the afternoon and you're probably waiting to have coffee, but I would ask you if you could just say hi with your name, your title, your affiliation, whether it's company, country, that would be super. You would do that normally in a conference in any case, so we hope you do that now, and it just adds to the kind of immersive feel, and that would be really appreciated. And I apologize if you do this as the morning I asked you on every session, but please do say hello so we know who you are, we can see you, and the others can see you as well. That would be great. Don't be shy is the key kind of take home for that. And I think that's enough from me, more than enough from me. And I think I'm going to hand the floor over to Dr. James Mulry from Merck Global Health Institute. Jim, over to you. I think we're good to go.
Hello, everybody. I'm Jim Mulry. I've got about 40 years in diagnostics. I've worked for companies like Abbott and Hariba in the past. Today, I'm going to talk about a program for healthcare strengthening. It's called the Malaria Microscopy Education. Essentially, we know that malaria is the #1 killer of children worldwide. And in endemic areas, the need for trained microscopists has really been increased. And so we've started a program to work on that issue. So just going through the statistics that you probably already are aware of, about 241 million get infected with malaria at any time. 96% of those live in sub-Saharan Africa. Last year, 627,000 died. 80% of them were children. Like I said, 95% of it was in Africa. The mortality rate increased 35% over 2020. And this was due mainly to all of the health ministries dedicating every resource they had to fighting COVID. And in doing so, neglected tropical diseases such as malaria and schisto were ignored. And it's a sad situation. There's very limited resources. Raising money to help, combat this situation has been difficult because the world's experiencing large amounts of inflation, and the charity dollars have become somewhat limited. But it's a major problem right now, malaria in Africa. It's the largest killer of children under 5. It's also the largest killer of children preteen. The other second group that's very much exposed is maternal mothers. About 6% result in mortality, miscarriages, and deaths during childbirth. It also is a big problem with low birth weight. So these are issues that have come up due to the 35% increase in malaria. So I worked with 2 groups in this project. I worked with the Rotary and with my team at the Global Health Institute. The Global Health Institute is basically a collection of researchers and managers. We work with outside organizations to combat infectious diseases. Primarily, our work is helping children and women in developing countries to combat infectious diseases. Primarily, we work in malaria and schistosomiasis, but we also work in other areas. It's a diverse team that has a holistic view of combating diseases. So we have a group of pharmaceutical PhDs that develop new compounds. I lead a team that develops new diagnostic assays, and we all construct, we do projects to enhance healthcare delivery in developing countries. And this is where the microscopy education comes in. We teach clinical microscopy to lab techs so that they can diagnose and phenotype malaria, but also diagnose the causes of other fevers. And essentially the way the program works is the Global Health Institute contracts with universities in these developing countries to conduct the training, and Merck pays for the housing, transportation, tuition, and feeding of the students for a full week of one-on-one training. And the Rotary raises funds to help me get much needed new microscopes, hemocytometers, and other products required for microscopy. Why microscopy? This is a question I get almost every day. Basically because microscopes are, number one, they're inexpensive, they're portable, they're easy to take care of, and they're easily transported. The number one growing area in sub-Saharan Africa, but also in Latin America, is ambulatory labs. These are labs on wheels, usually on vans or trucks, that can be driven into villages for health fairs. Usually they have like a malaria day, a women's health day, a children's health day, and depending on what is endemic in the area, days to address that. It's the reference method for looking at cells and phenotyping malaria. It's important to phenotype because there's 5 different species, as you well know, of malaria. About 33% of the Africans have a glucose disorder called G6PD. And if the wrong prescription is given, it can lead to clots resulting in strokes or heart attacks. Other methods have limitations here. The rapid diagnostic tests are great for screening a population for one specific malaria, but unfortunately they're not very sensitive. A few years back, I helped to develop Malaria Assays on an instrument called the Muse. It's being sold now by a company called Luminex. What we found out is in doing comparisons, the World Health Organization sent us the 3 kits that they recommend. And in all 3 kits, we found that they lacked sensitivity. There was false negatives, particularly on the low end. And so the limitation to rapid diagnostic tests is sensitivity. And you're going to miss some early detections where the medicine is most effective. The other part of it is it's very hard to phenotype because the rapid diagnostic tests can't do that. PCR is the reference method too. It can do phenotyping. It can do excellent sensitivity. The problem with PCR technologies, it's so expensive. The cost per test is usually $45 or higher. The cost of the instruments are way beyond the capacity for most of the communities that we work in. The average African family is a family of 6. It's got both parents, but the total income is under 4,000 US dollars a year. So you can see that we're going into a very cost-conscious market when we sell or we produce things in Africa. Just most of those communities just can't afford the PCR instrumentation. So again, how the program works, essentially the Global Health Institute will contract with the university. We ask them if they would mind one-on-one training. We need lots of microscopes and lots of professors to train 30 students at a time in clinical microscopy. We work with the health ministries because we want them to select who goes to the training. And the reason is, like any other skill, it's very tough to maintain the skills unless you're practicing it every day. And a skill like clinical microscopy takes 9 months to 18 months to really be comfortable knowing what you're looking at and making a diagnosis. We also work with NGOs that specialize in developing clinics and labs. Recently in Ghana, we worked with an outfit called Infanta, which is an NGO that raises money from the Society of Performing Arts in Ghana to build clinics for malaria in endemic areas. Before the students come, we filmed training webinars of all the procedures and all the lectures on cell morphology that are required as a background for the training. And the students get these webinars, there's 22 of them, about 2 months before they go in for training, so that they're prepared to do the one-on-one with the scopes when they get there. Another thing that we do is we spend a lot of time teaching them the classification of anemia, because malaria leads to anemia. We also go through leukocyte analysis so that they know that the causes of fevers, viral would be an elevated lymphocyte count or an elevated mono count. Certainly bacterial infections is an elevated gram count. An allergic reaction would see elevated EOs, and a toxic reaction will have the presence of basophils. So these are all things that we teach that that help with the education and help them to identify the cause of fever. This is an important issue around the world, whether you're in London or you're in Kampala or whether you're in Sierra Leone or any place. Sooner or later, people catch fever, and essentially what they do is they go to the doctor or they go into the hospital, and the poor physician is faced with what's the cause of the fever. The symptoms are the same for multiple diseases, be it dengue, be it malaria. So it's important to have a good microscope there and someone that knows how to look at blood analysis and interpret the results so that the physician can provide the accurate diagnosis and treatment. So I work a lot with the Rotary. The reason I work with the Rotary is I'm a member of the Rotary. I have to clear that out. I got started in the Rotary because of malaria. I worked with a group of Rotarians called Malaria Partners International. They've done some phenomenal work in the Copperbelt region of Zambia and also in Uganda and most recently in Mali. Essentially, the Rotarians have clubs all over the world. And if I'm looking for an honest broker to work with, especially if I'm transferring money to buy microscopes and other equipment, I need somebody I can trust. And so I've decided to work through the Rotary to do this. And essentially in each country where we work, there's a host club, and they'll collect the funds, purchase the microscopes, and deliver them to the right people in the healthcare authorities once the training is complete. And it helps me to avoid corruption, and it also builds tremendous relationships between those that donated the money and those that took the money and put it into good work. And so it's been beneficial for both parties. In starting this project, gosh, I really wanted to start in 2019, but we got hit with the COVID crisis. And so it got delayed and delayed, but finally last December, we had a successful training of 30 technologists at the Noguchi Memorial Institute for Medical Research at the University of Ghana. We had a Rotary host club, the host club of Ouija West in Accra, and they helped us collect the funds. There's pictures here of them delivering the microscopes from Radical Scientific to the Ghana Health Services. We purchased 32 of them. We donated some to the Infanta and some to the Ghana Health Services, and some we gave to the University of Ghana to train other technologists. One of the things that we've done is none of this training is worthwhile unless you get it accredited. And I worked closely with the African Society for Laboratory Medicine, and they helped us gain accreditation for the program through the European Union and also through VIT University in Johannesburg. So it's accredited. They get CPU credits. If they're Americans, it's CPUs, but the same thing. They get the credit for it. We received tremendous recognition from the government of Ghana. Mrs. Akufo-Addo is just the greatest lady. She was the one that suggested that we work in malaria in Ghana back in 2018 when we attended the Malaria Day festivities there. So now we're expanding and scaling up, as they said. This is a picture of Rebecca Akufo-Addo. Very nice, very, very nice lady. I was struggling with pronunciations, as I always do. If I hear a name, I just absolutely destroy it. And she turned around to me and she said, "Jim, just call me Becky." And since then, we've been pretty good friends. Ghana has a population of 29 million. Basically, all of them are exposed. At any given time, there's probably 8 million or so cases current. It's still the #1 cause of death there. Big problem, probably more than most places I go, is low birth weight and anemia. And they're doing a lot to combat this. Back in 2017, Ghana was deemed the worst malaria in the world. And since then, their government has gotten their act together, and they've expanded the hospitals. Right now, they're building 11 new hospitals. Infanta is an incredible organization. As I said, they work with the ACRIS, Society of the Performing Arts, and they get money raised through the opera, the ballet, and the symphony there. And I went to a meeting of Infanta. The ladies were in there celebrating and counting all the money that they raised, which buys and builds these clinics in endemic areas. This year, in fact, I just finished submitting the contract today, we'll be training an additional 40 technologists again at Noguchi. We're looking at November, December timeframe because we need to raise money for the microscopes. And again, the Rotary Club of Ouija West will help be in the host club. They're fantastic people. This year, as I said, we're scaling up. Nigeria probably has the most problems of any place that we're working right now. They've been hit with 3 pandemics at once. They're still struggling with COVID. They've had a huge epidemic of measles. It's also the 35% increase in malaria. So it's a country basically 265 million in the size of the state of Texas. 27% of the worldwide cases in the world are there in Nigeria for malaria. 272,000 died in the last 12 months. Big problem there is drug resistance. The chloroquine and other quinine derivatives sometimes don't work. And also is access to medicine. About 34% of those diagnosed go untreated. And those that there's a huge percentage of people that never get to even get diagnosed. Counterfeit drugs are everywhere. It's a situation where 216 Nigerians die every year. 80% of them are children. So we contacted River State University, and we're working with Professor Ibiri there to conduct the education. We're planning 30 to be trained in malaria microscopy. And the Health Ministry of River State has already selected the participants. I got the list yesterday, so we'll be going there. We have a host club, the Rotary Club of Port Harcourt Airport is our sponsor club, and they'll be the ones that purchase the microscopes and make sure that they get delivered to the right people. Nigeria is very, very friendly country. I wanted to say this. I've had years going back and forth to Nigeria, and they're among the nicest people I've ever worked with. They appreciate people that come in and conduct business with them. And if you go to Nigeria for a project, I highly recommend it because the appreciation in Nigeria is great. We just completed the malaria education in Botswana. Botswana is a very small country, about 2.5 million. In 2021, almost 2,000 of them were hospitalized, were also malnourished. So we have a big problem here. Botswana was the proving ground for DDT back in the 60s. And there's areas there where all the vegetation is gone. It's also caused long-term a huge cancer rate. It's one of the poorest countries that you could possibly go to. The financial resources are slim to none. Their whole malaria control board is about 9 employees, including only 2 laboratorians. So it's slim getting any help there if you have malaria. So we just did the class at the University of Botswana. We're getting help from the Rotary Club of Gourlaouen. And we basically just completed the class. We haven't delivered the microscopes yet. I have the money raised for it. We're just going through the logistics of how to get the microscopes into Botswana. But we had a successful class there. There's an NGO based in Ghana. It's called PAVAN, and it stands for the Pan-African Vivaccinovalia Network. And they helped conduct the training here. PAVAN is a great organization. Essentially, they're a legion of laboratories that span across sub-Saharan Africa. And they have very sophisticated PCR technology. And what they do is they basically identify malaria outbreaks. They phenotype the species of malaria there. We have all 5 species now in Africa. So it's important to phenotype, as I said, with G6PD and getting the appropriate medicine. Once they've identified an outbreak, they immediately alert the healthcare authorities. They basically can create epidemiological maps showing the outbreak and the direction and the projection. They also basically alert the media and give an explanation to the media in the local communities there so that they know what's going on. They do great work, and MGHI supports PAVAN, and PAVAN helps me get into countries where I cannot reach normally. So very good people. Dr. Isaac Quay is their director. We just also completed training in Burkina Faso. It's a French-speaking country, so I had to get all the material reprinted in French. Basically, they have about 22 million, and they're all at risk of malaria at any time. Last year, they reported almost 8 million cases and nearly 15,000 deaths. They're also seeing a huge problem that's different. It's insecticide resistance. The mosquitoes basically adapt to the insecticide spray and continue to develop. The mortality rate for malaria is high at 3.5%. About 32% of pregnant women with malaria go untreated. Again, PAVAN helped me here with the Institute of Research and Sciences, and we trained 30 technologists. Microscopes and trained technologists are in short supply, and we're working with the Rotary Club of Ouagadougou, Crystal, to host the delivery of the microscopes. There were a lot of concerns there, too, about getting the microscopes delivered. We've had complications due to corruption, and we're working through those. This winter, probably in December, we'll be going to Kakamega, Kenya, working with Masinde Muluro University. I have 3 gentlemen that I've known for years from previous experience, and the HIV arena. All of them were trained at Johns Hopkins. They're on the ground in Kenya, helping me set this up. Kenya, especially along Lake Victoria, is very endemic, and so we're going to work in Western Kenya over the next few years. They had nearly 3.5 million cases in Kenya just last year, and almost 11,000 deaths. Drug resistance is increasing in Kenya because many people have had multiple cases of malaria, and it just the drugs, how do I say it, the parasite adapts, and it's very tough. Also, many Kenyans have G6PD. So we're going to educate 30 students. We have a Rotary Club of nearby Saia that will be the host club. We are at this point still working through the contracting, but we're looking forward to going to Kenya at the end of the year. Another place that we'll be working this year is in Cali, Colombia. Colombia just elected a communist president, so this project is in jeopardy. I have people on the ground this week making sure that we'll still have clearance to go into Colombia and conduct the training. We're working with the Rotary there. This is the Rotary actually brought me into this project. It's a Rotarian group called Rotarians Against Malaria Global. And essentially, there's almost 50 million in the country. 10 million are at risk in endemic areas. There's about 81,000 reported cases. Most cases don't get reported. The area where we're working in Cali is an interesting area. It's surrounded by descendants of slaves that basically were freed years ago, and essentially it's a very poor area of Colombia. There's very few clinics there to work with, and so the need is quite significant there. So we contracted with the Universidad Santiago de Cali, and we're going to train. It's gone up from 30 to 50 technologists, so we're going to have 2 classes there. We have the money already for the microscopes here, and basically there's a district in Florida that basically got a global grant from the Rotary of over $150,000 to conduct 3 classes over the next 3 years. So we'll be going to different sections of Colombia, hopefully if the government lets us, and we'll be training people in clinical microscopy there. So right now I'm spending a lot of time conducting presentations within the Rotary and other charities. My goal is to raise $48,000 more for microscopes this year. Basically, we can wire the money directly to the host club in endemic countries, or you can contact me and I'll put the money in through an NGO called Pavan, or hook you up directly with one of the universities. But if successful, we will have Ghana, Colombia, Nigeria, Kenya, Botswana, and Burkina Faso this year. I've received requests to go all over the moon this next year. I don't know how I'm going to get all the money together for it, but there's a big need in Pakistan, Mali, Tanzania, Uganda, and Ethiopia. So that's got my immediate attention. If you'd like to help us out, you're welcome to contact me. This is my information. I work out of Switzerland, but mostly I'm in my office in Arizona, where I live. You've got my cell number and my email there. contact me if you'd like to help, or if you want to talk about an endemic region, or any questions that you have about the project or about the Global Health Institute. I'd be happy to answer. If you got any questions, it's a good time to chat.
Jim, absolutely fantastic. Mind blown, mic dropped. I think that's really going to open a lot of people's eyes in terms of what's possible out there with capacity.
Yeah, one thing I wanted to talk about, I did a presentation in Houston, and it was interesting. The Rotary is been famous for many years for the treatment of polio, and polio has been almost eradicated, and now they're turning their attention to malaria. And they hosted a meeting in Houston at the Petroleum Club there back on June 4th. And in the meeting was just about every group that you could think of that's involved in combating malaria. The CDC, World Health Organization, PAHO was there, UNICEF, UNAIDS, World Bank, Global Fund, Gates Foundation, you name it, they were there. And what we're trying to do is basically bring all these groups together to combine resources. As I said before, inflation's hurt everybody, and the donations for all these groups are down.
Yeah.
So we felt like we could get a better impact if we all combined resources. And one of the things that I'm doing next week is I'm meeting at the CDC with the President's Malaria Initiative and the CDC to talk about how industry, research institutes, and these NGOs can all work together to combat malaria.
Yeah, I mean, it's a huge effort, and a really interesting positioning of the Rotary in there, and how the host then has to communicate with all of the various groups. It's their responsibility to not a passive donor, very active in this whole model. I think that's fantastic. I think we're going to get a lot of questions that are going to come through from the audience, and I would ask the audience, please don't be shy. It's the last session. It's for you. You're not going to. It's a great chance to have such wonderful panelists with amazing work that they're doing. And the ramifications of this are way outside of malaria, so please do get your questions in. We definitely see the embryonics of a blueprint of how to engage and how to tackle this capacity issue from many different perspectives. So we really appreciate that, Jim. I think we'll have the Q&A at the end of the session, and it'll give the audience some time to put some questions in. We have quite a few questions to ask you, but this is really for the audience. And just on the audience for a second, I just wanted to give a quick shout out to some of the people that are here who have said hello. That's great. Antonia Asher, hi Antonia, great to see you. It's from Merck Schisto Elimination Program. Thanks for joining us. Professor David Rollinson from the Natural History Museum, actually the head of the Global Schisto Alliance from here in London. Great to see you. Dr. Kadima Jacob joining us from the DRC, working for the leprosy mission in the Congo there, so an interesting part of the audience. Dr. Kisoto Ogusan in terms of FHI 360 from Washington in the States. Great to see you there. Thanks for joining us. Dr. Tekelau Wulkiros, who from Hawassa University in Ethiopia, who's saying, I'm interested in point-of-care tests for infections, public health, the importance in my country, so Ethiopia. I think we should give you a medal, Tekelau, for being here on every session since the morning. So thanks for that, and we look forward to your questions. Carlos Texiria has joined us from Vitoria in Brazil, so that's fantastic as well. And I think Ebefun from Nigeria, I believe. Thanks a lot for joining us. And to the other attendees, please don't be shy. Just say hello. And you know, and we'll get into the quick Q&A at the end. I think Marianne's very kindly posted a session that we have on with Professor Isaac Kay in terms of a Connect session that we did a few kind of months ago. So that's on there as well for all of you to enjoy. Jim, thank you very, very much. I don't want to cut you off. We're going to move to the next speaker, and then we'll rejoin for the Q&A, if that's all right. That was fantastic.
Thanks for the opportunity. Last statement is the vision that I have is if we teach the core methods, the research methods, then we can bring in other technologies to help in Africa.
Oh, fantastic. This is, I think, why it's so interesting to everybody else. They can see that. I think it's a beautiful vision, very inclusive vision, and something that we can build on in the Q&A. So thanks a lot for that. Thanks a lot for that round of applause. And I think we're going to move to the next speaker. So we've heard there from Jim in terms of microscopy for malaria. We wanted to have a look at outside of that and kind of involve this One Health, at least the veterinary diagnostic kind of side of things. In the previous session, Hendrik Sadlowski from the NeuroCure Center in Berlin was talking about Taenia solium infections. He was looking at RNA sequencing of egg isolates from stool samples. But one of the points he made was that it's time to attach this to the kind of wider One Health approach, so we can start bringing in new, not just be in one silo and actually move to that multidisciplinary goal enshrined by the WHO's roadmap changes. So it's very good that very interesting that we're going to hear now about the veterinary diagnostic capacity. So enough from me. I'd like to introduce the floor to Dr. Morgane Gourlaouen from the Food and Agriculture Organization, the FAO of the United Nations. We've had Morgane very kindly in a Connect session before this, and it was specifically on rabies at that point. So it'd be interesting to hear how this fits into this kind of new FAO lab mapping tool. Enough from me. Morgane, the floor is yours. Over to you, and I'll back out.
Thank you so much. Thanks. Well, thank you so much for having me today. It was a pleasure to answer to this invitation to speak about capacity building. It's a topic that is, of course, very important to me, to us at the EMPRES laboratory unit at the FAO headquarters in Rome. So my presentation today is, the title is the Veterinary Diagnostic Capacities under Assessment. I divided my presentation in two parts. The first one is going to be on Laboratory Mapping Tool, which is basically a FAO family of tools. I will present them. Very important, very used. So it's a pleasure to speak about that today. This is going to be the main part of my presentation. And then the second part, it's only like a few slides right at the end. I can't prevent myself but speak about rabies because it also means a lot to me. So it's going to be on proficiency testing, how important proficiency testing are for capacity building of labs, with like a special focus on proficiency test for the diagnosis of rabies in Africa. Here we go. So I will start by speaking a little bit about who we are, what we do, and why do we do what we do, basically. So we are currently basically working within the One Health program priority area, as you can see on this slide. So it is an FAO strategic framework for 2022 till 2031, which seek to support the 2030 agenda through the transformation to a more efficient, inclusive, resilient, and sustainable agri-food systems for basically a better production, better nutrition, better environment, and a better life in general. So the four betters reflect the interconnected economic, social, and environmental dimension of any agri-food systems. So us at the EMPRES Lab unit, we are principally working towards a better production, so BP, as you can see here, BP3, better production umbrella, so that we work together with countries to adopt a strengthened and integrated early warning and information system. We also work with countries to develop and strengthen the national biosecurity to prevent epidemics and pandemics. This is very much into the also general context that the past, let's say, almost 3 years have been for us now. So building surveillance in countries means, of course, building laboratory capacity. I don't think that I will have to demonstrate that to the audience today. So we know that veterinary laboratories play a critical role in the detection, in the prevention, and the control of any diseases. And this is indeed including neglected tropical diseases. So in an ideal world, it's the way that things should work is that veterinary laboratory should sustainably and reliably be able to test for priority diseases under quality assurance and also following biosafety and biosecurity procedure. Vet labs should be part of any networks. This can be national, regional, international networks. And they should also be linked with epidemiological actors. And all of that meaning, like we were just saying before, that they are part within these One Health activities. Any type of One Health project, vet labs should be part of that. Looking at the domino effect that all of this would have within this perfect world, it means that basically basic and high-level diagnostic testing will be conducted to ensure reliable and secure diagnostic capacities. In return, meaning that you would have reliable laboratory data which would be produced and used by the animal and One Health surveillance systems for the decision-making, meaning that, of course, improved national capacities can be set up to prevent, detect, and respond to confirm animal health infectious disease events. So looking at the laboratory capacity building in general, if you want to properly improve, you need to start by understanding what are the needs. To do that, you need to do an assessment. And so the idea is that by having an harmonized way to do the assessment, you will have an harmonized way also to improve the situation. And the idea that we have is that this improvement should be done within with a stepwise approach. So you start by doing this assessment of needs, which allows you to design the program, like a specific program for any lab or any region or any countries, based on that needs, the needs that have been assessed. Allows you to implement new procedure or, I don't know, infrastructure, refurbishment or renovation. All of those implementation and improvements allows you to then report and advocate like the, goodness of what has been done, which allows you to then evaluate again and readjust the program based on everything that you've done. And then you go back and over time, you carry on with the assessment of the need, but constantly improving the situation. So what happened is that we understood that there was a needs from the countries for evaluation methodologies that would also focus on specific capacities. So several tools have been developed over the past few years, and those specifically for different parts here. So for those who may not be aware or familiar with those tools, for example, for the surveillance, a tool called SET has been developed. Of course, today we are going to be looking at the tool that was developed for laboratory assessment of laboratory capacities, so the LMTs. I will also speak here about the tool called Atlas, which has been developed for AMR, so antimicrobial resistance. This tool has been widely used already over the past few years. I think we are at more than 150 evaluations worldwide. And this tool also has a great feature called the PIP, which is the Progressive Improvement Pathway. And this PIP, I will be very succinct here, but this PIP basically allows to provide, it's like an automatic way to provide recommendation on both short-term and long-term. It has fantastic potential, and I would invite anyone interested in using Atlas to absolutely contact us for further information. Other tools also have been developed by other partners. I'm thinking about the PVS for the OIE and the GEE tool for WHO. And the idea is that all the tools basically can communicate with each other, because information and data used or produced by the tools, this is an interconnection of all the tools together. So going into the LMT, the scope of the laboratory mapping tool is to measure the strength and the gap of all key elements of an operational laboratory, and also to help prioritizing and planning capacity building activities. So the idea here is to allow countries and development partners to identify and prioritize action for improvements, evidence-based for action and advocacy. I think the word advocacy here is so important. It has been mentioned, and it will be mentioned, I'm sure, in the discussion afterwards. It is so important to have this ground to stand on to advocate what is needed for each laboratory or within a network of laboratory. So the LMT allows also the establishment of a baseline for laboratory status prior to an intervention, and it also allows to monitor the progress over time. We will look at that in a few slides. And there is also information that can be shared within the different assessment tools. So FAO SET or OIE PVS, WHO GEE. So the FAO LMT tools family are very easy to use. We are looking at a questionnaire, a standardized questionnaire for compilation of data. Here you can see, for example, an example. I hope you can see my cursor here. This questionnaire basically has, for each indicator, I will go back, you have 4 different scoring going from 1 to 4. A little bit like a quiz that, all of us, we did when we were teenagers, like doing quiz in magazines and things like that. You select the answers that correspond the most to the situation of the laboratory, and you accumulate points. And then at the end, you get like a total points. You get also the points for each category and each area. And this basically provides you indication to the different areas basically that the laboratory may need to improve, or the areas where the laboratory score 4 everywhere, meaning that the laboratory is actually doing very well and we can just carry on that way. So this LMT tool basically provides a systematic and a semi-quantitative analysis. That's pretty important. And it allows the generation of a laboratory profile that maps all the key elements of an operational laboratory. So I will start with the LMT core. We have within this LMT family of tools. There is the LMT core, and there is also the LMT biosafety and biosecurity. I will present those 2 LMTs today. So the LMT core basically look at the general profile of the laboratory. Oops. The infrastructure, equipment and supplies, the laboratory performance, the quality assurance, biosafety and biosecurity, and the lab collaboration and networking. So those are the 5 areas covered by the LMT core. Within these 5 areas, there is 17 categories, and those 17 categories are then divided in 108 subcategories that I also called indicator or questions. So as you can see here, I go back to the LMT. One of those lines here as what I call one of the question with like 1 scoring. This is what we call 1 subcategories or indicator. And so the LMT biosafety so really looks specifically at the biosafety and biosecurity measure in place at the lab, covers 5 areas, which are administration, operational, engineering, and personal protective equipment, PPE. This Excel file has, this Excel file has 20 categories and 98 subcategories to be selected and answered. So I would like to raise a very important point here, which is the LMTs are very easy to use. The LMT tools are actually available to download in French as well as in English on the FAO website. However, anyone that would want to use this LMT to a laboratory, I would highly recommend to contact us via mail because we provide short trainings on how to use the tool. It is very easy to use, but it has some little subtleties, which, a short training would just answer all of that. And we have, for us, it's very important to create this community of assessors or evaluators that know the tool and have been trained by us, so they know exactly how to use it, and they can, in return, of course, train other people to use it. So please, if you are interested, or if you know anyone in a laboratory anywhere in the world that would be interested, let us know so that we can organize a training. Usually, just to give you an idea, training for LMT core and LMT biosafety biosecurity takes up to 2 hours, and we also are very pleased to provide support after the evaluation to extract the results, but also to write the report, because this is not just about the evaluation. What's very important then is report writing and using the data that has been produced for the LMT to then advocate to stakeholders or, political maybe partners or political collaborators that could help financially or with external collaboration and so on. The ideas are really vast here. So once you have performed the evaluation in your laboratory, this is the type of results that you obtain. So you have here, as you can see, table. It's very simple, I think, data to extract and very simple data also to analyze. So you get a scoring for each of the categories here and a cut color. So indeed, categories scoring in red have lower score, indicating to the evaluator that within these categories, there is indicators that scored very low, and of course indicating that if improvement needs to be made, then those are the areas that should be targeted and should be basically aimed. So each lab basically can define its priority for the corrective action on the gaps that has been measured, and lab management basically based on those results also can be taken. So the LMT offers the possibility to also monitor progress over time. The idea is to assess the laboratory regularly. You don't need to assess every 2 months or every 6 months. You need time to actually, implement the measures and action. So usually we recommend to apply the LMT every year or every other years. And then, as you can see, you can just put next to each other the different assessments that were performed, and then you can measure also the progression over the years. And this, once again, for advocacy, provides numbers, provides solid data to show what has been done and how important it is for capacity building to invest, of course, time, efforts, money, and to see really what has been done to be able to properly measure that. So the LMT provides the possibility to measure the progression over time of one laboratory, but also to do it within a network. So you can put all together, the assessments done within a regional network of laboratories or national network of laboratories. This is, international network. This is kind of endless, let's say. In any case, those results compiled like this together can be, once again, a solid ground to stand on for harmonized approaches, and also to understand maybe common gaps for laboratories at regional or national levels. So I hope that here you will agree that the LMT basically provide, using the LMT results, you can discuss the results with each laboratory. This is something that has to be done after each evaluation. This provides a good ground again for discussing the next step based on the findings and the recommendation, but also to plan the strategic activities and define the priorities for the corrective action, and to measure the progress over time. So at national level, national discussion can be undertaken. And once again, you have grounds and you have solid data to go and advocate for investment, time, effort, and money. I will stop here on the LMT, and I will move towards the second part of my talk, which is another way of assessment here. So we are not assessing, let's say, the laboratory as a whole. Here it's more about the diagnostic performance and the assessment, basically, of sample analysis. So this is called proficiency testing, maybe for people that may not be too much in the laboratory. So proficiency tests, we have been commissioning at FAO PT, we call them, for quite a while now. So avian influenza, Newcastle disease since 2008. And then in 2015, we started to commission a proficiency test for rabies with the FAO reference center based in Padova, called the ISNTD. And lately, last year in 2021, we started the proficiency test for brucellosis with the OIE reference laboratory based in Teramo. And upcoming, we have the Rift Valley fever proficiency testing. Hopefully this is an oncoming activity, hopefully for next year. Just to say, those proficiency tests are taking place at this moment mostly in Africa. So we are working with a network of about 15 to 25 laboratories. It depends on the disease. And I cannot emphasize, how much proficiency testing as such an important tool. It's not just an important tool because it helps us to measure the lab performance and understand whether a laboratory is able to provide reliable data. But actually, it is also a great way to identify gaps, and also it's a fantastic window for us to start discussing with the laboratories and to do troubleshooting when various problems basically are being pointed out. I'd like to say that as quality assurance of laboratory becomes more and more tendance, subject that comes very often. It is mandatory from the ISO 17025 point of view, which is the ISO under which diagnostic laboratories should be working. The revision from 2017, basically including participation to interlaboratory comparison or proficiency test as not just a necessity, but mandatory requirements as often as possible. It doesn't have to be every 6 months, but every year, every other years, depending on the disease. So regarding the diagnosis of rabies, we organized a proficiency test in 2021 to which 15 African vet labs basically participated from 12 countries. So we had central veterinary laboratories as well as some regional veterinary laboratories. So that's a really nice network of lab. I hope you'll appreciate that. And this proficiency test is to us super important, of course, because we know whether a lab can analyze or not sample suspected of rabies. Most of the laboratory, they use either the RT-PCR or they use the DFA, so the immunofluorescence test. But this proficiency test is also for us a way to check, for example, the rabies vaccination status of the staff. Unfortunately, often laboratories do not have a good cover of the lab staff. So those PTs basically are a good way to check that. And as I was saying before, this also opened a great way for us to communicate with the labs. So we really invest time in follow-up activities and technical assistance. The idea is not to look at the results and say to a laboratory, oh, you can do it or you cannot do it. No, the idea is for a laboratory to say, okay, you can or you cannot do it. You had some issues there. We can see some false results. But it's actually to then set up meetings, meet with them and understand why did they have a wrong result. What can we do to modify that? Is it a problem of reagents? Is it a problem of training? Maybe we just need to redo a training and, send some experts on the ground so that, they can retrain service staff. And that goes hand in hand with the talk of Jim just before. Okay, maybe we need to do consolidation on molecular diagnostics. So we just need to organize a specific mission for that. So proficiency testing are this whole package, I hope you'll understand, of activities, not just the assessment, of the diagnostic protocols. So when we do those PTs, we provide a questionnaire, which is quite detailed to each laboratory. So that gives us a good kind of overview of the situation of each lab. As I said, the rabies vaccination is updated. So a laboratory won't receive the PT panel unless the lab presents a good vaccination coverage of the staff. And I will invite you, if you're interested, to go a bit further to read the paper that we published on Plus NTD about 2 years ago now. We organized at the time, that was in 2018, the first large-scale PT for rabies in Africa. And that PT was also for us a way to implement real-time PCR to many of the labs that participated. Before that PT, most laboratories were using the immunofluorescence to detect rabies. And we used that proficiency test as a way to also implement the RT-PCR. Laboratory received the primers to do the PCR, and testing those PT samples. That was a great way for us to understand whether or not they were applying that real-time, conventional actually, RT-PCR properly. So I hope that you will appreciate here that, those PT, for me, it's very important, and are not just a way to check protocols are properly applied. It's much more than that, and that's why it's very important to carry on investing time in organizing proficiency testing, and for, of course, as many diseases as it is possible basically to have. Here we go. I think I will stop here for now. I thank you very much for the invitation. It's a pleasure really to speak with you today. And if you have any question, super happy to answer them. Thanks.
Thank you very, very much, Morgane, for that wonderful presentation. This whole LMT self-assessment bedrock of the first part of your presentation, very, very interesting indeed. And I'm sure there's going to be a lot of questions coming through from the audience. This is the final session, so I would say to everybody, please feel free to put your questions in. We have quite a few questions to ask, but this is really about you as the audience. So Jim's joined us back there again. So wonderful, wonderful news. Thank you both very, very much for a brilliant, thought-provoking kind of session there. Just to start off with, a few weeks ago, I'm not going to take credit for this statement, but I'm going to give you the history of it. A couple of weeks ago, I was in Singapore for our dengue, World Dengue Day meeting and the Asian Dengue Summit. I had the pleasure of a couple of meetings with the DNDi that were out there. So Dr. Isabella Ribeiro, Dr. Jean-Michel Pierre Daganel, Director of the Southeast Asia DNDi. And Jean-Michel actually mentioned something to me. He mentioned about perhaps turning capacity building on its head and talking about capacity use. Both of your approaches struck me, I'm sure the audience would agree, as very, very inclusive. So the LMT with its self-assessment, kind of, then the labs talk for themselves. And Jim, in yours, in terms of the training of the local kind of people in terms of the technical training, the certification of that training as well, which is very important. Kind of, they get something from this, the people who are involved in this project. And I dare say it's one of the positive components that's allowed you to spread all the way from all across the different countries you've mentioned, Nigeria, Botswana, Burkina Faso, all the way now out to Colombia with a view to other countries. So very inclusive, both sets of work, both very, very inclusive. So the question is, do you think we're shooting ourselves in the foot when it comes to sustainability by talking about capacity building? Should we be talking more?
I think it's critical that we keep within sustainable products, and also this training becomes sustainable. Part of our program, we contract with the university to get postdocs to do a year later impact and sustainability study. This helps us to ascertain what worked, what didn't work, how we can improve the system, but also the skill levels of those being worked with. And I think it's quite important.
Yeah, good answer. Morgane, in terms of your input to that?
Yes, I really go back to what Jim said. Like, to us, basically, the idea is that using the assessment, once again, we are not doing this assessment to say, oh, this laboratory has nothing, or has no. What we need to do is that we need to then use the results of this assessment as advocacy to go towards the stakeholder to, force a little bit that sustainability, saying, look, this laboratory has this and that and that. That network of laboratory has this and that. What does it need? It needs reagents. How can we improve the system so that none of the laboratory within this network is lacking reagents and can properly perform diagnosis of certain diseases, like as it should be doing?
That's a fantastic answer, and again, it speaks volumes to the inclusive nature of the mindset behind both of the projects and the deployment of them. So fantastic. In terms of, so there's another question. In terms of, let's say, the political class, both of you have mentioned, some kind of element of the political class, as it were, that you've leaned onto the policymakers. With Morgane, you were mentioning, Morgane, you were mentioning the potential in terms of national surveillance and inputting into that. At some point, and I dare say, Jim, your rollout could be inputting into national surveillance programs as well. At some point in that process, you're going to need the full backing of the political class, as it were, the policymakers. And you seem to be doing that quite nicely. Any tips to the people who are in the audience who might be finding that difficult in terms of getting to those policymakers? So I'll ask Jim that first, if you don't mind.
Well, I think Morgane there hit on it, since you start with a needs assessment. And in my case, I try and involve the malaria control boards and the healthcare deliverers, as well as I utilize the President's Malaria Initiative to get the data that I need to present for the needs assessment. And then I meet ahead of time before the project's even initiated. I have a general meeting with all those involved in the project. The Rotary, the university, the health ministry, the NGOs that were working in the area, and I basically present that data there, and then say, "Hey, do you want to work on this? And can we work on it as a team?" It takes a lot of teamwork, and it's not easy just to pull off at the out of your sleeve. It's something that takes preliminary work. It's usually 9 to 10 months of work before I can actually schedule a class.
That's amazing. And I know we've been speaking informally off and on since 2019, before that even, about microscopy and about what you were doing in this particular area. So it's beautiful to see it kind of now in operation, as it were. So it is fantastic to see. Morgane, in terms of you lent a little bit on the national surveillance programs. How do you anticipate this system? Would you think LMT will become the standard way that labs can assess themselves across these regions? Is that your ideal endpoint? And how do you think you're going to get to that?
Yeah, absolutely. Like this would be, indeed, any laboratory, any vet lab that would like to use the LMT is more than welcome, basically, to use it. And yes, the idea is that we work hand in hand together with the FAO colleagues in national FAO offices, in like all the different countries, to train the people on the ground to use the LMT, and to then exactly, as you said, over time, to every other year, to use those LMT together with the SET tool, which is a really, really good tool for surveillance assessments, basically, of the surveillance system in every country. So the two tool works really together. And, exactly like Jim's were saying, then, of course, it takes months and a great effort of like team working for then go and advocate, for like the needs that arose from those assessments. Mm-hmm.
That's fantastic. Great answers. That's the horrible P word, the policy maker. We've used the P word. The F word, financing. Everybody hates this word. You mentioned the Rotary Club there in terms of their kind of involvement in this. I think on one of your slides, Jim, you put that the Rotary, the host donor, is in charge of communication in that region or in that locality. Is that normal in these kind of settings, or is this something that you've kind of
it's something that we've created? I've been going back and forth into developing countries now for nearly 40 years, and you've got to have people that, especially when you're dealing with money, but also with products, you need someone you can trust on the ground. And government can only go so far to help you. And so what I liked, I spent 3 years with the Rotary, going to Malaria Partners international meetings and ran global meetings before I joined. And I built up, they built up their trust in me, and I built up my trust in the organization. They do an incredible job teaching leadership and screening people to manage projects, particularly in developing countries. I just returned from the Rotary International meeting in Houston, and I was amazed. I've gone to a lot of medical meetings, but I've never been to a meeting where they had 70,000 people attending.
Yeah, wow. Yeah.
Yeah. They're from all over the world, and I spent 4 days in a booth just constantly talking, and it was interesting feeling out the different needs in the different countries.
That's a fantastic answer. So kind of a different kind of dimension for the donors. In terms of financing your project, Morgane, and how you see it rolling out, how do you see that happening? What would be the steps, or how do you see that happening?
What do you mean exactly?
In terms of further financing of your particular approach, how would you see that kind of evolving to get to national level, or to get to the kind of level that you want to get it to?
Yeah, well, I think as long as we provide basically as long as we carry on providing basically the results of our efforts, it's exactly like, I mean, Jim was saying, it's a matter of like working all together with our partners, because trust is there. So investment carries on also because there is the trust that we are doing what we're doing in the right way. And, over time, and also not just that we are doing in the right ways, that we are specifically doing countries by countries, answering precisely to the demands. So the finance then would just, naturally derive because we offer a specific solution for each country based on the needs that. So I guess that as long as we carry on all working hands in hand, together, hopefully, we will be able to carry on the financement over the next few years.
Fantastic. A great answer, keeping that local context and allowing that to drive sustainability by releasing political will, let's say, and sovereign capital. Yeah, absolutely. A great answer. That's the kind of that's the kind of financial question on that. In terms of partnerships and moving forward, Jim, you've mentioned different countries there, and I know we're speaking about malaria context, but how do you see this, in all honesty, evolving? Because it's going to be a rapid evolution. If you're talking of, you're already there in those countries, a great footprint, and you're talking about Colombia, you're talking about Pakistan, Mali, and that's on malaria. How do you see those partnerships evolving outside of malaria?
Well, one of the game plans is to come back and address other disease states because of Merck's commitment to fighting schistosomiasis. All these countries are going to get back with us in a few years, and we're going to go in and teach microscopy for schistosomiasis. And we can take each disease one at a time and relate it to the microscopy. The second phase is going to be, as I said, introducing affordable but accurate medical technologies that can enhance the delivery of diagnostics there. And we carefully look at all these different technologies and screen them, and hopefully we'll apply it once the technologies have been at a state where they're affordable and we can use them. Okay.
That's a great answer. So you're open to those partnerships, and it probably will happen at the end after schisto and after malaria. Right. Yeah, the network is there, and it's it makes a lot of sense. Morgane, in terms of your One Health approach and NTDs, that world, those two worlds, have you had any challenges in terms of, or have you got plans to move and bring different diseases in? You mentioned some of them in your presentation, but have you had challenges around that, communicating this to the NTD world, as it were, or not?
Of course.
Yeah. Bien sûr. Yeah. Yeah.
And NTDs are challenges, right?
Yeah.
The idea, of course, is like with NTDs, and I guess any diseases, especially working with low and middle income country, is really to work within this One Health approach. I think this is the way that we can counteract all the challenges that we can have with NTDs, is working all together, following the One Health approach with the different partners. And this is what we do, especially for rabies, for example. This is with one of my colleagues. It's a disease that really means a lot to us.
Yeah.
And yeah, the One Health approach is definitely the way forward to go against the challenges. I mean,
I can only imagine what Margot must go through just getting the samples that she needs for research. It's got to be a major challenge.
Yeah.
Yeah.
That's a very interesting answer there, actually, Morgane, for that. There are a few questions that are coming through, and I'm wary of the time, so I do want to honor the fact that some attendees have put some questions in. I want to answer this. So there's a question from Carlos, Dr. Carlos Teixeira, I think from Brazil, and he's asking, this is to Jim, but I'm going to paraphrase that backwards to Morgane as well in a different way. But what he's asking is, it's interesting that while everyone is usually focused on molecular diagnostic methods, we see the role of microscopy still has a role in the real world. And he's asking, what are the criticisms, or I guess resistors, that this initiative has faced so far? Have you had any resistance, Jim, at all to this?
Oh, yes, I've had plenty of resistance. Sometimes you go in and you're treading on somebody's personal empire, and you have to be careful with that. I learned that in Ghana. Getting into why the microscopy versus, say, PCR or other technologies. With PCR, as I said, it's very expensive. But second of all, it's a trained operator. And unless you know the core science, the core methodology, it's going to be useless going in and trying to push a heavier technology. And I go into places where there's not a lot of technology available at this time. And it just behooved me that microscopy is going to be affordable. It's going to have multiple applications outside of malaria. And it can lend a hand in other areas. You're not going to be able to classify anemia or see other co-infections without a microscope.
Oh, fantastic. Thank you for that answer. Morgane, I think I've kind of asked you that in terms of in a way, in the previous question, in terms of any resistance that you had and from NTD world, or that kind of melding, as it were. So you've answered that, I think, nicely. There is a question from Dr. Kisito Ogusan from FHI 360, and he's asking, how do you foresee QA and QC will be built in local ownership now based upon your current field experiences? And that's to both of you. So we can ask Morgane that first, or we can ask Jim that first. Whoever wants to answer first, you're welcome. But it's to both of you. How do you foresee... Ladies first, Jim.
Well, I guess that's the way that we are looking at quality assurance, basically in general, at this moment, is to work within, once again, a network. Laboratories, basically, around, we have this network of vet labs, and they all work together. We have, for example, monthly meetings. They share experience together, and they build basically their knowledge on quality assurance, quality control. They build this knowledge basically over time, communicating with each other, doing annual conferences where they can discuss together, building roadmaps as well, so that, they can, once again, using the assessment of the LMT, we build roadmaps, and we know step by step how we can develop basically the quality quality assurance basically in laboratories.
That's a great answer, very detailed answer. Thank you for that. Jim, any input into that in terms of this QA and QC building on local ownership, built into local ownership?
Well, what Margot's team is doing is essential, and it hasn't been done before, particularly in Africa, and it certainly hasn't been done in the veterinary world. The veterinary world remains completely unregulated, and it's a challenge. It's been a huge high profit margin for those that are involved, and much more so than clinical diagnostics for humans. I always thought it was funny. People will scream at having to pay $12 for CBC from a lab, and when they go and take the dog to the lab, they'll gladly pay $85 for the same test.
Priorities, yeah. So that's a good. But
then I can understand. Sometimes when I've been on the road too long, the dog is the only one glad to see me at home.
Someone has to. That's a good answer. There is another question that's come from Dr. Lyven Stuver from the Johnson & Johnson, and I'm sure you already know this, or if you don't, for the audience, Lyven has been working on artificial intelligence as an additional layer on microscopy within the schisto kind of settings. And he's asking a question. We've had a Connect session a year or so ago with Lyven, and that's all on our website as well to have a look at. But he's asking, can you compare standard microscopy to artificial intelligence-based microscopy?
We're working on our first one. The Global Health Institute has a collaboration with Janssen, part of J&J, and we're developing an automated platform for schistosomiasis to do CATO-CATS exams using an artificial intelligence microscope. It's been roughly 4 years in development. It's not been an easy project to do, but certainly it's showing signs of coming along. I mean, that's one example I can think of, but you go to any of the medical meetings now, especially in diagnostics, artificial intelligence is everywhere, from chemistry analyzers to hematology analyzers to lab information systems. It's all over the place, and hopefully, eventually, right now it's pretty expensive, but hopefully one day it'll reduce the cost of healthcare delivery, particularly for those in emerging economies.
That's a great answer. I just wanted to ask this last question, I guess, because there are no more questions coming through from the attendees. So I'm going to ask this one. You've both got training components in your approaches. How far are you considering in the future, let's say, digital opportunities for training, online learning, that kind of channel to then potentially lower the costs of not having to be in that country, but use that to scale it out? Is that something that you're thinking of?
We're doing it. As I said earlier, we filmed 22 webinars on lectures about the morphology and how to conduct the procedures, mainly because not only to prepare students for the hands-on training, but also to reach out to those in countries and areas where I can't get there, but the training is desperately needed. They can pull up the webinars on our website or on the ASLM website or on the University of Ghana website and get the training that they need free of charge.
Oh, that's fantastic. So you're already actually doing it. Morgane, are you in a similar vein?
Absolutely. I mean, what happened in 2020, we, like, as you said, training is like a huge part of our, job. And I'm also speaking about the LMT evaluation. It's not because like the pandemic started in 2020 that we had to stop that. So as we do, I think humans, we're great for that, is that we adapt. we adapt and we try to adapt as fast as it was possible. So to develop learning material so that, trainings can be done from remote. We've also managed to do evaluation assessments and trainings also for the LMT from remote. But I mean, Jim, I'm sure you will agree with me. At the end of the day, I think for technical training, there's a part that can be done online. And, of course, all the theory about a disease and the diagnostic and the techniques and so on, this can be done online. But there is that practical part that I think is hard to replace with a computer. This exchange of skill and knowledge at some point, I think, require a face-to-face meeting. So hopefully all of this can start again now that the world seems to be a safer place. Here we go.
Napoleon said you could drill there's no substitute for combat.
You got talk for a second. I did not expect it.
So we're ending on a quote from Napoleon. Okay, so great. Excellent. Yeah. So I think, I've been told we have to be at the end of the time allocated for the session. I'd like to say there's never enough time to discuss these things. 1.5 hours is just 1.5 hours, right? But you guys have really covered an amazing amount of work and really translated that for the audience. I think that was a fantastic couple of presentations, and one that's got a lot of future-facing activity in it. It's very, very interesting to see, and I wonder how that's going to roll out. Very excited for both of you in terms of the rollout of that. It's excellent. So, round of applause from everybody here for both of you making time, and all of that, yay, and everything. Really appreciate that. Now, the audience, thank you very, very much for making time for this last session. Some of you have been here throughout the day. Thanks for sticking through all of that, and I hope you had a good day. You've been amazing audiences in each of the sessions. People are saying thank you, thanks all. Kisoto Ogusan saying thanks all. Ebu Afong, thank you. A lot of people saying thank you in that. And I think, we're going to be releasing all the videos of this, editing and video in the next week or so. So no one will miss any of it. We'll be putting that all out there as we do. I really hope our paths cross in person. Yeah. And the best of luck with everything. Dr. Liebensteiver, Johnson, thanks for great meetings and presentations. You really struck a note. Carlos Texeria, thanks to presenters and to Rafiq. My mother used to call me that when I was in trouble. But Carlos, thanks for the flashback of that. Thank you. Edith, thank you all for the great presentations. So all of the quiet audience are now coming alive, which is fantastic. Brilliant. Thank you, Edith, for that. Thanks for the questions, everybody. Angelique Angot, thanks so much for these great presentations. You've really hit a kind of a resonance with a lot of people there. So I just wanted to say thanks to everybody. We will be putting all the videos out. It's been a fantastic 2 days. From India, Dr. Narayana Samai, good and useful session. Thank you all. And thank you all for joining. I think I'm not good at goodbyes. You've probably noticed that already. I'm trying to say goodbye. I hope we meet in person soon. All right. I'm going to press the button. From me, adios, and have a great rest of the day. Stay safe, keep cool, stay lucky. Yeah. Take care, everybody. All right. Thanks a lot.
Bye-bye.
Bye-bye.
Thanks so much.